Assalamu alaikum and good morning. I wanted to thank Professor Tariq Hashim and his team for organizing this fabulous educational activity. I also want to thank them on behalf of my mother and my family for naming this lectureship after my late father's name. This year's honored guest for the memorial lectureship is truly an icon in Pakistani neurosurgery. Before I present our honored speaker to you, I wanted to show this note by my late father written on the back of a photograph. It reads, "The highest peaks in human life are not attained by getting, but rather by giving. What you do for yourself dies with you. What you do for others lives forever." This is a quote frequently attributed to Sir Isaac Newton, the famous English mathematician and scientist. It reads, "If I have seen further than others, it is by standing upon the shoulders of giants." Our honored guest today is one of those giants who has helped many see further and helped them achieve more during their careers. Professor Tariq Salahuddin, FRCS, FCPS. Professor Tariq Salahuddin is currently the Professor of Neurosurgery, Head of Department of Neurosurgery, and Dean of Postgraduate Studies at National Defense Hospital in Lahore. Before this, he has also held many prestigious positions, including the Professor and Head of Department of Neurosurgery at Lahore General Hospital and PGMI. Bright and driven from the beginning, Professor Saab returned to Pakistan to serve his country after finishing his training at prestigious institutions all over the world. There's a long list here. There's Regional Hospital in Cork. There's Midland Center in Neurosurgery. There is Great Ormond Street Hospital for Sick Children. There's George Washington University, and there's Sick Children's in Toronto. A lot of prestigious institutions. Professor Salahuddin is an accomplished neurosurgeon. Some of his areas of expertise include vascular neurosurgery, transsphenoidal neurosurgery, and surgery of the sellar region, neuroendoscopy, and spinal neurosurgery. Professor Saab has also served Pakistan Society of Neurosurgeon and also was its president in 2010 and 11. He's also served in Asian CNS and WFNS in many capacities. In addition, he has served CPSP, College of Physicians and Surgeons of Pakistan, University of Health Sciences. As you can see, his list of publications is also long, a lot of contribution and peer-reviewed journal articles throughout his illustrious career. Professor Saab is a dedicated teacher, an academician at heart. He's known for his passionate and engaging talks. He has been and continues to be a very sought-after speaker nationally as well internationally. It's a long list of presentations that he's done over his career. Professor Saab has also served and continues to serve on many prestigious neurosurgical journals. He is on the Asian Journal and also serves on the Neurosurgery, the official journal of Congress of Neurosurgeons, as a member of the editorial board. Possibly his biggest contribution towards neurosurgery in Pakistan is the establishment of Punjab Institute of Neurosciences in Lahore, which is now a wonderful to-go place for neurosurgical patients in Pakistan. On a personal note, I've had the privilege to have grown up as Professor Salahuddin and Mrs. Salahuddin as good friends to my late father and my family. He has also been a very kind and enduring friend to my late brother-in-law's family, whom he has known for decades. Professor Tariq Salahuddin is a good man and always a friend in need. Ladies and gentlemen, it is my distinct honor to present Professor Tariq Salahuddin.
Thank you, Ali. I am humbled by your kind words and the introduction. Chairman of ICRAN, Professor Tariq Khan, President, Pakistan Society of Neurosurgeons, Salman Khan, and my dear friend and guest of honor, Professor Gail Rousseau, delegates from all over the world, Pakistan, and ladies and gentlemen. It is an extreme honor and privilege for me to present Iftikhar Ali Raja Memorial Lecture. I'm going to talk about the role of decompressive craniectomy in TBI, traumatic brain injury, the recommendations internationally, and what need the way forward. 10 million cases leading to hospitalization or death each year. In the United States, TBI affects 1.5 million people every year. Treated medically and surgically, decompressive craniectomy is life-saving procedure. But the dilemma between death and life with severe disability is open to ethical debate. The most recent disease burden study on TBI, published in 2019, actually suggests that more than 27 million people suffer from TBI and are admitted, and deaths each year based on 2016 data. This review provides an overview of the current evidence base, discusses its limitations, and presents a global perspective on the role of DC, as there is a growing recognition that the attention should also focus on low and middle income countries due to their much greater TBI burden. Traumatic brain injury remains a major public health problem worldwide. It is a leading cause of mortality and disability across the globe. With low and middle income countries facing the greatest disease burden, brain swelling and intracranial hypertension are well-recognized secondary insults associated with increased mortality and poorer outcomes. Decompressive craniectomy refers to the practice of removing a large bone flap and opening the underlying dura in order to control brain swelling and raise the intracranial pressure. This review aims to present the evidence base concerning the role of DC following TBI, to identify areas of uncertainty and to discuss future directions. Objective adequate management of increased intracranial pressure is critical in patients with traumatic brain injury, and decompressive craniectomy is widely used to treat refractory increased intracranial pressure. I think the only indication remains to be raised ICP refractory to best medical treatment. I think it is the initial prevention of ICP, avoidance of hyperexia, sedation, intubation, non-intensive ventilation, and followed by an active treatment of raised ICP, which is hyperosmolar therapy, CSF withdrawal, infection risk, negative fluid balance, cardiac overload, and electrolyte disorders. But the aggressive treatment of ICP rises, metabolic suppression, hypothermia, decompressive craniectomy plays a major role, hypocapnia, risk of hypothermia, secondary hematoma, hydrocephalus syndrome of Trepine, arterial hypotension, coagulation disorders, and chest infections. If you look at the historic background, the initial history of the this procedure was probably traced back to BC 4000 in cast refined the skull of different therapeutic or superstitious reasons. The oldest refined skull found at a Neolithic Bruxelles site in France is more than 7,000 years old. The first specimen of refined skull was found in 1685, again in France, and in 1816, a second specimen was found by Alexander Francois Babi du Bois at the Nogentlis-les Vigeurs. In 1960s and 1970s, DC was not welcomed due to its poorer clinical outcome. 1968, Jamieson and Yelland reported results for successful surgical treatment of traumatic epidural hematomas with a mortality rate of just 16% in series of 116 patients. A very good paper was published from Massachusetts General Hospital, Boston, Massachusetts, Bifrontal Decompressive Craniectomy for Massive Cerebral Edema. In 1971, reports 73 cases, 50 cases with TBI using a bifrontal DC with duroplasty for severe brain edema. The survival rate was 18%, among them 22% in cases of TBI. 1971, Rensoff and Benjamin reported the result of treatment of subdural hematoma by wide decompressive hemicraniectomy with durotomy, which resulted in 40% of survival rate and 28% patients returning to preoperative condition. In 1980, Gerald and Tavon reported that extensive bilateral DC with durotomy offers the possibility of rapid reduction of ICP. 70% of patients died and 20% of patients recovered. In 1990, Gabb et al. Performed a postoperative study with 37 patients younger than 40 years. They performed 19 bifrontal craniectomies and 18 hemicraniectomies. They reported 5 cases of mortality. All others achieved full recovery or remain moderately disabled. The treatment outcome was mostly affected by the initial post-traumatic GCS less than 7. This paper, again from Southern California, United States, decompressive craniectomy, surgical control of traumatic intracranial hypertension may improve the outcome. It concluded that the DC lowers ICP and raises CCP, cerebral perfusion pressure, to high normal levels in survivors compared to non-survivors. The timing of DC showed no clear trend for either good neurological outcome or death. Overall, the survival rate of 74.4% is promising, and 41.9% had favorable neurological outcome. Presently, there are 3 major trials: decompressive craniectomy in raised ICP, DECRA; trial of DC for traumatic intracranial hypertension, RESCUEicp; surgical trial in traumatic cerebral hemorrhage, STITCH trial, where our department, when I was in Lahore General Hospital, was also involved. This paper, published in the New England Journal of Medicine, Decompressive Craniectomy in Diffuse Traumatic Brain Injury, 2,000 to 200 in 2010, 155 patients who had TBI and either GCS lower than 8 or CT demonstrating moderate diffuse brain injury were enrolled. Patients with refractory ICP greater than 20 for 15 minutes within an hour period were randomized to 2 groups, and 72 patients performed DC plus maximal medical care, and 82 patients had maximal medical management, including the barbiturate and hypothermia. It concluded that DC decreased ICP and the length of stay in the intensive care, but it is associated with more unfavorable outcomes. There was certain criticism regarding this trial. Uneven randomization of patients. More patients who had non-reactive people were enrolled in DC group, 27% of the other had 12% in medical therapy group. If it adjusted, the unfavorable outcome showed no difference between 2 groups. Choice of surgical method: only bifrontal DC without Fox sectioning was allowed in DC in DECRA trial, and it resulted the advantages of surgical treatment were not prominent. Refractory ICP in this trial was too low in pressure and too short in duration. It could not be sure it really reflects intractable increased ICP. Absent standardized rehabilitation, long enrollment period, less concern of CPP are the weak points of this trial. Again, another very good paper in the New England Journal of Medicine, Decompressive Craniectomy for Traumatic Intracranial Hypertension. Multi-center, 48 centers, 19 countries, RCT study named RESCUEicp for 10 years from 2004. 408 patients aged between 10 and 65 years, TBI and refractory elevated ICP greater than 25 were randomized to undergo DC or receive ongoing medical treatment. Patients with bilateral dilated pupil, bleeding diastasis, devastating injury, brainstem damage, and impossible follow-up were not included in the study. At 6 months, decompressive craniectomy in patients with traumatic brain injury and refractory intracranial hypertension resulted in lower mortality, higher rates of vegetative states, lower severe disability, and upper severe disability than medical care. The rates of moderate disability and good recovery were similar in these 2 groups. There were certain limitations in RESCUEicp. Non-blinded clinical teams who cared for the patients were aware of trial group assignments. large proportion of patients in the medical group underwent DC, 10 patients excluded from all analysis owing to withdrawal of concern or to lack of valid consent, and 7 more patients in the medical group were lost to primary follow-up. Long-term data on cranial reconstruction were not systematically obtained owing to the pragmatic nature of the trial, did not examine the effectiveness of primary DC, which is undertaken more frequently than secondary surgery. I think this was another very important study by the Health Technology Assessment in year 2015, surgical trial in traumatic intracerebral hemorrhage, which is called STITCH, and randomized controlled trial of early surgery compared with initial conservative treatment. Multi-center pragmatic parallel group trial, patient was randomized via an independent neurosurgical units in 59 hospitals in 20 countries. The study planned to recruit 840 adult patients. Inclusion criteria was patient had to be within 48 hours of head injury with no more than 2 intracerebral hematoma greater than 10 ml. Exclusion criteria, patients extrasubdural hematoma or extradural hematoma that required evacuation or any severe morbidity that would mean they could not achieve a favorable outcome if they made a complete recovery from their head injury. What did it conclude? This is the first ever trial of surgery for TICH, which is the traumatic intracerebral hematoma, and indicates that early surgery may be a valuable tool in the treatment of traumatic intracerebral hematoma, especially if Glasgow Coma scale is between 9 and 12. As was also found in surgical trial in spontaneous intracerebral hemorrhages, STITCH, and surgical trial in spontaneous lobar intracerebral hemorrhages, STITCH 2. The methodology is, I think, depending upon what is the line of treatment that the surgeon chooses. Benefits of DC directly affect by surgical technique. 2 main techniques widely used for DC in TBI are unilateral frontotemporoparital craniectomy and bifrontal craniectomy. In our experience, overtriage, hypoxic, hypotensive patients, hardly any swelling intraoperative, acute subdural hematomas, temporal contusions, systemic injuries, do very well after surgery, 60 to 70%, ended with cranioplasty. Undertriage, delayed surgery, poorer outcome, bifrontal injuries, 5% of all severe head injuries should require DC. Most centers, about 25%. Our indication was clear-cut, direct clinical signs of RESCUEicp and radiological signs of RESCUEicp. None of these procedures were without complication. Herniation through the craniectomy defect, 27%, subdural effusion, 21%, post-traumatic hydrocephalus in 9.3%, and syndrome of Trefine in 13% perform early cranial repair before the skin flap sinks within 8 weeks after craniectomy. Remember that in patients with TBI, early cranioplasty may increase the risk of infection and thus is not recommended. Is the most common DC complication after 1 month. Contralateral hematoma after decompressive craniectomy in about 7% patients. Operation and early direction intervention are key in the management. I would like to thank my able colleague, Dr. Shahzad Shamim from AKU for his contribution nationally and internationally towards the traumatic brain injuries and the research papers which were published internationally. The phenytoin versus letrozole for seizure prophylaxis, the indication of tracheostomy and cranial reconstruction after decompressive craniectomy, prediction of complication with using physiologic. I think at the end, I would like to show you these few slides. And do you think that small device like this is the cause of a lot of accidents worldwide? A lot of people don't. That is the reason why we ask you to observe closely the following pictures. You will probably change the way you think. Roses that never reached their destination. They could have been for her mom, dad, or brother. We will never know. All we know is that it could have been avoided. Please be careful whenever you drive. Do not use the cell phones. Thank you for your attention.